Welcome back to the Vital Signpost. I'm excited for today's deep dive into diuretics. We'll be breaking down their mechanisms, nursing considerations, and really getting into the nitty-gritty of how they work.
Sounds like a plan. Diuretics are essential for nurses to understand, that's for sure.
Before we get into the drugs themselves, let's talk about where they work. The kidneys. They filter waste and keep our electrolytes balanced, all thanks to these microscopic structures called nephrons.
Each nephron is like a tiny winding filter with different sections, right? It starts with the glomerulus, that's the first checkpoint, filtering out the larger stuff in the blood.
Like a sieve, letting the good stuff through and catching the waste.
You got it. The filtered fluid then goes on this journey along the nephron. Along the way, the body reabsorbs the things it needs, like water, electrolytes, glucose.
So the nephron decides what stays and what goes, basically. What's left becomes urine, right?
Exactly. And that's where diuretics come in. They act on different parts of the nephron, tweaking this process to get rid of excess fluid and sodium, super important for managing things like high blood pressure, heart failure, and edema.
So they're like fine-tuning the kidneys, making sure we don't hold on to too much fluid. Fascinating. Okay, so let's get to the different types of diuretics.
We've got 5 main categories, each with its own way of working. Starting with the least potent, we have carbonic anhydrase inhibitors. They inhibit the enzyme carbonic anhydrase, which is key for sodium and bicarbonate reabsorption.
So they're stopping the nephron from reabsorbing as much sodium and water, leading to more urine output.
Precisely. Acetazolamide is the common example. It's used for edema, glaucoma, and you might be surprised to hear high-altitude sickness.
Oh, wow, really? Didn't know that one. Guess these drugs wear many hats.
They do. But it's important to remember they can impact the body's acid-base balance. We need to watch for metabolic acidosis, especially by checking electrolyte levels.
Metabolic acidosis, yeah, that's when acid builds up in the body. Important to keep that in mind. Okay, what's next on the list?
Loop diuretics. These are powerful and fast-acting. They work on the loop of Henle, the part of the nephron responsible for concentrating urine.
Fast-acting. How fast are we talking?
When given through an IV, they can work within minutes. Essential in emergencies like pulmonary edema.
Wow, that's quick. What makes them so strong?
They block sodium, potassium, and chloride reabsorption in that loop of Henle. So you get a huge increase in urine output, flushing out excess fluid rapidly.
If the previous ones were making small adjustments, these are like calling in a plumber for a burst pipe.
Great analogy. But with that power comes a greater chance of side effects. Electrolyte imbalances, especially low potassium, are a big concern.
Hypokalemia, right. That can lead to muscle weakness, fatigue, even heart problems, if I remember correctly.
That's it. Furosemide, better known as Lasix, is the classic loop diuretic. It's used a lot for heart failure, high blood pressure, anything where fluid buildup is an issue.
Furosemide, the workhorse of the diuretic world. So what comes after those powerhouses?
Osmotic diuretics. These guys work a bit differently. They increase something called osmotic pressure in the nephron, pulling water into the tubules and preventing it from being reabsorbed.
Osmotic pressure, that sounds complicated.
It's basically like this. Imagine you have a very concentrated solution on one side of a membrane and a less concentrated one on the other. Water naturally wants to move from the less concentrated side to the more concentrated side to even things out.
Okay, I sort of get it. So these drugs create that concentrated environment in the nephron and pulls the water out.
Exactly. Mannitol is the main osmotic diuretic. It's mainly used in critical care for things like cerebral edema, where reducing pressure in the brain is crucial, also for acute renal failure.
So a more specialized tool, not your everyday diuretic. Got it. What's up next?
Potassium-sparing diuretics. These ones are interesting because they actually help the body hold on to potassium, which we know can be a problem with the others.
That sounds like a good thing, considering the risk of hypokalemia. How do they manage that?
They work in the distal convoluted tubule and collecting duct, blocking the action of aldosterone, a hormone that normally increases sodium reabsorption and potassium excretion.
So they're essentially stopping the body from getting rid of potassium.
You could say that spironolactone is the key example here. It's often combined with other diuretics, especially those loop diuretics, to counteract their potassium-losing effects.
A balancing act, then, using different diuretics to get the right fluid and electrolyte levels. Makes sense.
And of course, potassium-sparing diuretics can also have side effects. You have to watch for hyperkalemia, too much potassium, especially in patients with kidney issues or those taking other potassium-increasing medications.
Right. It's always about finding that balance. Okay, what's our last category?
Last but not least, thiazide and thiazide-like diuretics. These are probably the most commonly prescribed diuretics, especially for hypertension.
Thiazides, yeah, I've heard of them. Often used for high blood pressure, right?
Yeah. That's right. They inhibit sodium reabsorption in the distal convoluted tubule, leading to increased urine output and reduced blood volume, which lowers blood pressure.
So they're like the everyday workhorse of the diuretic world.
A good way to put it. Hydrochlorothiazide, or HCTZ, is the most common one. It's been around for a while, very effective, and generally well tolerated.
Well tolerated. But I thought thiazides could also lead to potassium loss.
You're right, they can. Even though they're generally well tolerated, they can cause hypokalemia, just like loop diuretics. Monitoring potassium levels is crucial.
Okay, so watching those electrolytes, especially potassium, seems like a big theme across all these diuretics.
Hmm.
What other things should nurses keep in mind when caring for patients taking these medications?
That's an important question and something we'll cover in detail later. But first, let's look at a case study from our material. It involves Dr. G, a 54-year-old professor diagnosed with hypertension, who was prescribed hydrochlorothiazide, that HCTZ we just talked about.
Sounds interesting. What can we learn from Dr. G's case?
Well, she was complaining of fatigue and admitted she'd been taking her HCTZ in the evening because she was worried it would interfere with her teaching. Turns out that timing was probably part of the problem.
How so?
Diuretics can cause nocturia, making you have to get up to urinate during the night, so she was likely having trouble sleeping.
Trying to be proactive but ended up making things worse. It really shows how important it is to talk to patients about medication timing, doesn't it?
Absolutely. Finding a schedule that works for their lifestyle without disrupting their sleep is key.
Communication is always key, that's for sure. What else did Dr. G's case highlight?
The importance of dietary education. She said she was drinking orange juice for potassium, which is good, but a broader understanding of potassium-rich foods is important, especially with thiazide diuretics.
Right, it's not about just one magic food, but a well-rounded approach to diet. So how were Dr. G's electrolytes?
Well, her potassium was a bit low at 3.4 MEQL. Not critically low, but definitely something to keep an eye on.
A little yellow flag then. Something to monitor and maybe adjust her diet accordingly.
Exactly. Catch those changes early. Now, to make things even more interesting, 6 months later, Dr. G was diagnosed with type 2 diabetes and started on oral hyperglycemics.
Oh, now we have to think about drug interactions too.
Precisely. Thiazide diuretics can actually increase blood glucose levels, so now we need to emphasize close glucose monitoring and potentially adjust her diabetes medication.
It's all connected, isn't it? Managing one condition can have implications for another. So much to consider.
It is. Dr. G's case really shows the complexity of diuretic therapy in the real world. Assessment, monitoring, communication, patient education, it all comes into play.
I'm already feeling like I have a much better grasp of diuretics. So what's next?
In the next section, we'll really dive into the nursing considerations. What specific assessments do you need to do? What are the key things to monitor? How do we best educate our patients? All that good stuff.
Can't wait. I'm ready to get practical.
Excellent. I think you'll find it very useful. So let's dive into those nursing considerations we touched on. How to make sure we're using these medications safely and effectively. For nurses, it's a big part of our job.
It is. I'm ready to hear what you've got. Any insights on caring for patients on these meds?
Well, it all starts with a good assessment before we even think about giving any diuretic. Medical history, current meds, allergies, a focused physical exam, it all matters. Vital signs, weight, intake and output, listening to those heart and breath sounds, checking for edema, and looking at their skin, it all paints a picture.
It's like getting a baseline. Right.
Yeah.
Seeing where the patient is at before we start so we can track how they respond to the diuretic.
Exactly. And we can't forget about assessing their understanding of their condition and why they're taking this medication. Empowering patients with knowledge is a big part of nursing.
Definitely. The more they know, the more likely they are to stick with the plan and take their meds correctly.
That's so important. We need to explain things clearly, like the potential side effects. Things like dizziness, lightheadedness, muscle weakness, changes in how often they pee. They need to know when to call their doctor, if something feels off.
Empowering them to be aware, to watch out for any red flags.
Exactly. And of course, monitoring doesn't stop after that initial assessment. It's ongoing. We're checking those vital signs, weight, intake, and output regularly, and keeping a close eye on those electrolytes, especially potassium. Hypokalemia and hyperkalemia both can happen, depending on the type of diuretic.
Like walking a tightrope. making sure the medication is doing its job without throwing those electrolytes out of whack.
A good way to put it. And we have to remember, older patients might be more sensitive to these drugs, more at risk for dehydration and those electrolyte imbalances. Got to be extra careful with them.
Speaking of being careful, that case study with Dr. G, the professor with hypertension who was prescribed HCTZ, it had some good reminders about things we need to think about.
It did. Remember how she was taking her HCTZ at night? Well, that was likely contributing to her fatigue because of the nocturia, having to get up to pee at night. We need to talk to our patients about the timing of their medications.
Right, even with the best intentions, they might not realize how the timing can affect them.
Absolutely. And remember how she was just drinking orange juice for her potassium? It's a start, but a more well-rounded understanding of potassium-rich foods is important.
It's not just about finding one magic food, but a healthy overall diet.
Exactly. And her potassium, remember, it was 3.4, a bit low, a sign to be proactive, maybe adjust her diet some more, keep a close eye on things.
A little warning sign, right?
Yeah.
Okay, and then she was diagnosed with diabetes and started on those oral hypoglycemic meds. Things just got a lot more complicated.
They did. We have to consider those drug interactions now. Those thiazide diuretics, they can actually increase blood glucose levels.
Wow, really? Didn't realize that.
Yep. So close monitoring is even more important, and we may need to adjust her diabetes meds too.
It's like a puzzle, isn't it? Managing all these pieces together.
It is. Dr. G's case is a perfect example of how things work in the real world.
It definitely is. So beyond those specific cases, what are some key objectives for nurses when it comes to diuretics? What should we be focusing on?
Well, first, we need to know those different classes of diuretics inside and out, how they work, where they act in the nephron.
Like we were talking about before, those carbonic anhydrase inhibitors, loop diuretics, osmotic diuretics, potassium-sparing, and thiazide diuretics.
Exactly. Each one is unique. And then, of course, we need to know how they're used throughout the lifespan, treating different conditions, from childhood to older age.
Different needs at different stages of life. What else should we be thinking about?
The nursing implications. How to assess and monitor patients, how to educate them, how to make sure they're taking the medications safely.
Right, it's more than just giving the pills, it's the whole picture.
Exactly. And we need to be able to calculate dosages accurately, especially those IV meds. No room for error there.
Definitely. Safety first.
And then how to evaluate whether the treatment is working, both from those objective measures like vitals, weight, lab values, and from what the patient tells us, how they're feeling.
Putting it all together. And of course, we have to teach our patients about these medications, what to expect, potential side effects, all that.
Absolutely. Knowledge is power, right?
It is. Okay, so we've talked about objectives. What about key points? What are some of the most important things to remember about these medications?
Well, the bottom line is diuretics increase urine flow. They stop the reabsorption of sodium in water, so the body gets rid of more fluid.
Makes sense.
And they're mainly used for hypertension and edema, the kind of fluid buildup you see with heart failure, cirrhosis, kidney disease, and glaucoma, and increased intracranial pressure too.
They're used for a lot of different things then.
They are. But we can't forget about those side effects. Dehydration, electrolyte imbalances, especially hypokalemia, they're all possible.
Right, we talked about that before. We got to be watching for those things.
Exactly. And that's why patient teaching is so important. We need to explain those potential side effects, how to adjust their diet, and why they need regular checkups.
Makes sense. Okay, so those are some key points. What about key terms? What are some of the words nurses need to know when we're talking about diuretics?
Well, diuresis is a big one. It basically means increased urine production. That's what these drugs do.
Right, getting rid of that extra fluid.
Then we have electrolytes, substances that break down into ions when they're dissolved in water. Sodium, potassium, chloride, calcium, those are all important electrolytes. They play a role in all sorts of body functions.
And edema, of course. That's the swelling from too much fluid.
Exactly. And then we have those electrolyte imbalances we keep talking about. Hypokalemia, low potassium, and hyperkalemia, high potassium.
Both can be dangerous.
They can. Okay, now let's test our knowledge a bit. The material has some review questions that can help us solidify what we've learned.
Sounds like a good plan. Fire away.
All right, first question. The nurse is looking at the meds for a patient who's about to get a new order for a loop diuretic. Which of these could potentially interact with the loop diuretic? Vitamin D, antidiabetic drugs, penicillins, NSAIDs, corticosteroids, or warfarin?
Okay, let's think about this. We know loop diuretics mess with electrolytes, especially potassium, and they can affect blood pressure and how the kidneys work.
Exactly. So other meds that also mess with those things could cause problems.
All right, so let's go through them. Vitamin D, I don't think that interacts directly.
Nope. And penicillin's not really a problem either.
But what about those anti-diabetic drugs? Don't those affect blood sugar?
They do, and loop diuretics can affect blood sugar too, so that's one to watch. What about NSAIDs, those painkillers?
Those can be hard on the kidneys, can't they?
You bet. They can reduce the diuretic effect and make kidney problems worse, so that's another one.
Okay, and corticosteroids.
Those can actually worsen hypokalemia on top of what the loop diuretic is already doing.
So we've got 3 potential culprits then. Anti-diabetic drugs, NSAIDs, and corticosteroids. Tricky.
They are. It's all about recognizing those potential interactions. Okay, next question. We're monitoring lab results for a patient on a loop diuretic and a thiazide-diuretic. Which lab value would we be most concerned about? Decreased potassium, increased calcium, decreased glucose, or increased sodium?
Well, we know loop and thiazide diuretics get rid of sodium, potassium, and chloride. They can also mess with calcium and glucose levels.
Good summary. So which of those options is the most likely problem?
Decreased potassium. Hypokalemia.
You got it. Those drugs increase potassium loss, so that's a big one to watch. All right, next up, we've got a patient taking spironolactone, which lab result would be a red flag. Sodium of 140, calcium of 10.2, potassium of 5.8, or magnesium of 2.0.
Okay, spironolactone, that's our potassium-sparing diuretic. It holds on to potassium.
That's the key.
So a high potassium level would be bad. Is that one of our options?
It is. A potassium of 5.8 would be a major concern. That's hyperkalemia.
Okay, I'm starting to see the pattern here. Understand how the drug works, and then think about which electrolyte imbalance is most likely to happen.
Exactly. Okay, next one. A patient with heart failure is taking spironolactone daily. Which of these must we include in our teaching? Eat high potassium foods, avoid high potassium foods, avoid grapefruit juice, or follow a low-fiber diet?
Well, if spironolactone is already saving potassium, then wouldn't eating more potassium be dangerous?
You are absolutely right. We need to tell them to avoid high potassium foods.
Okay, that's counterintuitive to what we usually teach with other diuretics.
It is. Got to remember those differences. Okay, moving on. We have a patient with diabetes who's starting a thiazide diuretic. What do we need to teach them?
Thiazides and blood sugar, that rings a bell. Didn't we say those could interact?
We did. So what's the most important thing to teach this patient?
To watch their blood sugar levels closely, because the thiazide might make them go up.
You got it. Okay, next scenario. An older adult is being discharged after being treated for heart failure. He's going to be taking a loop diuretic. What are the most important things to teach him? Take the diuretic at the same time every morning. Take it only if he sees swelling in his legs. Stand up slowly because it might make him dizzy. Drink at least 8 glasses of water a day. Avoid potassium-rich foods. Or call the doctor right away if he notices muscle weakness or more dizziness.
Okay, lots to think about. We're talking about an older adult, so safety is a big concern, and loop diuretics can cause dizziness.
Good thinking.
So taking it at the same time every day is important, helps him remember, and definitely standing up slowly to prevent falls. And he needs to know to call the doctor if something seems wrong, like muscle weakness or that dizziness.
You nailed it. Okay, last question. It's a dosage calculation. The order says, give mannitol 0.5 grams per kilogram IV now over 2 hours. The patient weighs 165 pounds. We have a 100 milliliter vial of 20% mannitol. So how many grams will the patient get, and how many milliliters do we need to prepare?
Okay, first things first. We got to convert pounds to kilograms.
Right. There are 2.2 pounds in every kilogram. So 165 pounds divided by 2.2 gives us 75 kilograms.
All right, now we can calculate the total dose. It's 0.5 grams per kilogram, so 75 kilograms times 0.5 grams per kilogram. That's 37.5 grams total.
Perfect. Now for the milliliters. Our solution is 20%, meaning 20 grams of mannitol for every 100 milliliters.
You think. If we need 37.5 grams and we have 20 grams in every 100 milliliters, then we need 187.5 milliliters of that solution.
You got it. Dosage calculations are so important. Always double check those numbers to keep our patients safe.
Absolutely. Well, I feel like we covered a lot of ground there. What's next on our diuretic journey?
Now that we've covered the basics, let's dig into some of the details from the chapter text. We'll get into the specifics of each diuretic class and how they work. So we've got those 5 main classes of diuretics, right? Carbonic anhydrase inhibitors, loop diuretics, osmotic diuretics, potassium-sparing diuretics, and thiazides.
Right. Each working in its own unique way.
Exactly. So let's look closer at those carbonic anhydrase inhibitors. They're not as commonly used as some of the others, but they have their place. They mainly work in the proximal tubule.
That's the first part of the nephron, right, where the initial filtering happened.
You got it. And these drugs, they block the action of carbonic anhydrase, which is an enzyme that helps reabsorb sodium and bicarbonate. So when you inhibit that enzyme, you get increased excretion of sodium, water, and bicarbonate.
Leading to more urine output. Okay, I'm with you. So what are these carbonic anhydrase inhibitors used for?
Well, they're sometimes used for edema, but they're also used for glaucoma to lower the pressure in the eye. And believe it or not, they can be used for altitude sickness.
Really? Altitude sickness. That's interesting.
Yeah, it's not their primary use, but they can be helpful for that. Now, one thing to keep in mind with these drugs is that they can cause metabolic acidosis.
Because they're messing with bicarbonate, which is involved in acid-base balance, right?
Exactly. So we need to be mindful of that, especially in patients who already have kidney problems or acid-base imbalances.
Makes sense. Okay, let's move on to those powerhouse diuretics, the loop diuretics.
Ah, yes, the loop diuretics. These guys work in the loop of Henle, and they're known for their potent and rapid effects. They're like the big guns when it comes to getting rid of fluid fast.
We talked about that earlier, right? How they can work within minutes when given IV.
Exactly. So they're really important for those emergency situations like acute pulmonary edema, where you need to get fluid off quickly. They're also used for chronic conditions like heart failure and kidney disease.
And how do they work exactly? What's happening in that loop of Henle?
Well, they block the reabsorption of sodium, potassium, and chloride. And because that loop of Henle is so important for concentrating urine, when you block that reabsorption, you get a big increase in urine output.
So it's like turning up the volume on the urine production.
A good way to put it. But of course, with that power comes a greater risk of side effects. Electrolyte imbalances are a big concern, especially hypokalemia. They can also cause ototoxicity.
Ototoxicity, what's that?
The damage to the ears, which can lead to hearing loss. It's not super common, but it's something to be aware of, especially with high doses or prolonged use.
Okay, good to know.
Yeah.
So what about those osmotic diuretics? Remember you said those worked a bit differently.
They do. Osmotic diuretics, they work by increasing the osmotic pressure in the nephron. Think of it like this. You have a solution with a lot of particles in it and a solution with fewer particles. The water will move from the area of low concentration to the area of high concentration, trying to even things out.
Okay, I sort of remember that from high school chemistry. So these drugs, they create that area of high concentration in the nephron.
Exactly. They pull water into the tubules, and then that water gets excreted as urine. They don't really affect electrolyte reabsorption as much as the other diuretics.
So they're not as likely to cause electrolyte imbalances.
Right. That's why they're often used in specific situations, like to reduce intracranial pressure in cerebral edema or to protect the kidneys in acute renal failure.
So they're more specialized tools. Okay, what's next?
Potassium-sparing diuretics. These are important because they help the body hold on to potassium.
Which, as we've discussed, can be a big problem with the loop and thiazide diuretics.
Exactly. So these potassium-sparing diuretics, they work in the late distal convoluted tubule and the collecting duct. They block the action of aldosterone.
Yeah, aldosterone, that's a hormone that normally increases sodium reabsorption and potassium excretion, right?
You got it. So by blocking aldosterone, these drugs prevent sodium from being reabsorbed, and they also prevent potassium from being lost in the urine.
So they're kind of like the potassium protectors.
That's one way to think about it. Spironolactone is the most well-known potassium-sparing diuretic. It's often used in combination with other diuretics to balance out those potassium losses.
Makes sense, but I guess we still need to watch out for too much potassium, right? Hyperkalemia.
Absolutely, especially if the patient is taking other medications that can increase potassium levels.
Okay, so potassium, always a balancing act. What about those thiazide diuretics?
Ah, the thiazides. These are probably the most commonly prescribed diuretics, especially for hypertension. They work in the distal convoluted tubule, inhibiting sodium reabsorption.
Just like those potassium-sparing diuretics.
Similar area, but slightly different mechanism. Thiazides don't block aldosterone. They have a direct effect on sodium reabsorption.
So they also increase urine output and lower blood pressure.
Exactly. Hydrochlorothiazide, HCTZ, that's the most common one. It's cheap, it's effective, and it's generally well tolerated.
But it can cause hypokalemia, right? Just like those loop diuretics.
It can. So monitoring potassium is important for this class too. And another thing to keep in mind with thiazides is that they can interact with other medications.
Like those diabetes medications we talked about earlier.
Exactly. They can also interact with lithium, digoxin, and some other drugs.
So always important to check for those interactions.
Always. Okay, so we've gone through all the classes. Now let's shift gears a bit and talk about those patient-centered lifespan considerations.
Right, thinking about how these drugs affect people of different ages.
Exactly. So let's start with pediatrics. When we're giving diuretics to kids, we have to remember that their kidneys aren't fully developed yet.
So they might process the medication differently.
They do. They're more at risk for dehydration and electrolyte imbalances. We need to be really careful with dosing and monitor them closely.
Makes sense. What about pregnant women?
Diuretics are generally avoided during pregnancy unless it's absolutely necessary.
Because they could affect the baby.
Right. Some diuretics can cross the placenta, so the risks and benefits need to be carefully considered.
Okay, so a lot of caution there. What about older adults? What do we need to keep in mind?
Well, older adults often have age-related decline in kidney function, so they might be more sensitive to the effects of diuretics.
And they're already more at risk for dehydration.
Exactly. And falls, too. Some diuretics can cause orthostatic hypotension, that sudden drop in blood pressure when you stand up, that can lead to dizziness and falls.
So we need to be extra careful with older folks on diuretics. Monitor them closely, make sure their environment is safe, all that good stuff.
Absolutely. Okay, so we've covered those lifespan considerations. Now let's talk about something that's really important for all patients, regardless of age. Patient education.
Empowering them to take charge of their health.
Yeah.
What are some key points to cover when we're teaching patients about diuretics?
Well, first, we need to make sure they understand why they're taking the medication, what condition are we treating, and how does the diuretic help.
Explain it in simple terms, no medical jargon.
Exactly. And then we need to talk about potential side effects.
Mm.
Increased urination, dizziness, lightheadedness, muscle weakness, changes in bowel movements. They need to know what to expect.
And what to do if something doesn't feel right.
Right, when to call their doctor. And then we need to teach them how to take the medication correctly, the dosage, the timing, whether they need to take it with food or not.
All those little details that make a difference.
They do, and we need to emphasize the importance of following their doctor's instructions. Don't stop taking the medication without talking to their doctor, even if they feel better.
Right, consistency is key with these medications. What else?
We need to talk about diet. Depending on the type of diuretic, they might need to adjust their potassium intake. Either increase it, or in the case of spironolactone, actually decrease it.
Right, we talked about that earlier. It depends on the drug and how it affects potassium.
Exactly. And then we need to encourage them to follow up with their doctor regularly so we can monitor their progress and make any necessary adjustments to their treatment plan.
It's a team effort, isn't it? The doctor, the nurse, and the patient all working together.
It is. Okay, so we've covered a lot of ground today. We talked about the kidneys, those amazing filtering organs, and how diuretics work to get rid of excess fluid. We went through all 5 classes of diuretics, their mechanisms of action, their uses, and their side effects.
We looked at a case study that highlighted the real-world challenges of diuretic therapy. And we discussed the importance of nursing considerations, like assessment, monitoring, and patient education.
We even tackled some dosage calculations.
We did. I feel like I have a much better understanding of diuretics now.
That's great to hear. Remember, this deep dive is just the beginning. Keep learning, keep asking questions, and always put your patients first.
Great advice. To our listeners, thanks for joining us on the Vital Signpost. We'll be back soon with another deep dive into the world of medications. Until then, stay curious, stay informed, and keep those vital signs strong.